Welcome to all the participants to our Zoom session. Today is our 328th Zoom session. For the last 327 days, we are continuously conducting this Zoom session without any break. International Forum for Promoting Homeopathy is an organization formed with the intention of promoting homeopathy all over the world. Our only intention is to promote homeopathy and unite the homeopathic doctors together in one platform. This organization is a non-religious and non-political organization formed with the interest of homeopathic lovers and homeopathic doctors. Our only aim is to promote homeopathy and share the knowledge and experience with others in this platform. So today's our guest is Dr.Shyama Bora from India. She graduated from CMPHM Medical College and she got her PG from YMTHMC Mumbai, and she's practicing since about 10 years, and she's the founder of Sparsh Homeopathy and started teaching from 2016 onwards and working in Chandaben Mohan Patel Homeopathic Medical College as a professor of in Department of Physiology, and gave series of lecture in practical utility of organon for the participants of 6 months practical course designed by Dr. Gorang Gaikwad, and worked with him for his book, The Art of Repertorization. Dr. Shyama Bora, welcome to our Zoom session. Please. You can talk, you can unmute and...
Yeah, okay, thank you. Thank you, everybody. I'm absolutely honored to be here today, in middle with all your amazing homeopaths. And I've gone through the website and I saw you, continuously conducting Zoom sessions every day for so many days. It's quite a, magnificent task that you've done. So I really congratulate all of you for that. Thank you for inviting me.
Okay, now you can start your. You can start your class. Today's our subject is hormonal.
So so I'll be talking about hormonal harmony with homeopathy.
Homeopathy, and your time is up to 9:15. Then
9:15.
Yeah, 9:15.
Okay, perfect.
Then we will have a questionnaire.
Okay, perfect. Okay. So before starting my presentation, I'll just give a brief overview of why this topic is a topic of interest for me. When I did my post graduation, after my post graduation, I worked with a doctor in Mumbai who started practicing very much on infertility cases, and she named her center as an infertility, as a painless fertility center, and where we saw a lot of cases pertaining to infertility, whether it's female infertility or male infertility, and from there my journey to be to understand the hormonal state and its impact or its role in maintaining the normal physiological functions of the body I started getting more interest in that. And as we saw more and more cases, we also understood the various modern medicine options that the patients have, and what is our role and where do we fit in what cases can we give better results. So that was something that drew me towards studying more and more hormonal cases. And I'm sure all of us in our practice would have seen that we do have a lot of scope in hormonal disorders, whether it is pertaining to infertility or pertaining to hypothyroidism. So I'll just try to put in my experience. I'm sure all of us would have. It's not something that it's not something that not many homeopaths go through. All of us would have been experiencing that, but just I'll share my experience or my journey through what cases I have solved or what learnings I've had throughout. So I'll just start with my presentation. Yeah, is my presentation visible?
Yes, yes.
Yes. Okay. Thank you. Thank you. So, so currently, I'm actually teaching physiology in CMP College in Mumbai, and being a physiology professor, I'm all the more close to the normal functioning of hormones and the role that they play in maintaining the homeostasis, as we say, or the health that is we aim at when we are treating anybody. So that makes me much more fond of the topic, being a teacher of that subject. When we talk about hormonal imbalance, there is the concept of psychoneuroendocrine axis that we need to understand, or that is the current understanding of evolution of any disease. So we believe that the psycho, the CNS, or the emotions are they're interlinked with our neurals, the nervous system, the endocrinal system, and our immunity. And that is how, when in homeopathy, we always wanted to look for the emotional state of the patient, or the mental state of the patient. Somewhere, we were not finding the answer of why it is important for us to know the mental state. But now, even the modern medicine understands this as a phenomena where the mental state has its correlation with all the three aspects, which which are responsible for maintaining homeostasis, or which are responsible for maintaining health in any individual. That is the nervous system, the immunity, and the endocrine system. So when we are aware of this particular aspect, that our mental state is going to govern these, or is going to affect the three aspects of or the three pillars that are required to maintain health, the corollary of which is that we will require, or we will have to understand the mental state of the patient, especially of those who are undergoing endocrinal disorders. And that's how a lot of endocrinal disorders we'll find have a correlation with either some mental aspect, or some stress, or some constant mental state that the patient would have been through. And not only for hormonal cases, but for all in general, treating all cases, this is an access, or this is an understanding that is going to be required by us, to know that our emotions are going to be interlinked with our immunity, with our hormonal secretions, and with our the nervous system, especially the autonomic nervous system, that is the parasympathetic and the sympathetic. So this correlation is always going to be there in the back of our mind when we are solving any cases, or when we are treating, or we are managing any diseases. This is something that we need to be aware of, and we need to keep that in our background. uh, when we all know what kind of hormonal diseases that we can manage with homeopathy. Now, it's important to understand the point of management of the cases, because there may be a lot of cases that you may not be able to cure completely, but as a hormonal imbalance, it's very important to manage them with what other alternative therapies, or what other allied advices or auxiliary treatment that you are going to offer to the patient. So managing a case of hormonal imbalance is, or it can come in various forms, like PCOS or PCOD, or any causes of female infertility, male infertility, altered testosterone levels, or any altered thyroid levels. But in all these cases, or in each of its diagnoses, it's important to understand what are the causative factors, and what are those factors which are going to maintain these illnesses. So, for example, if we want to talk about PCOD, it's essentially called as a lifestyle disorder, and therefore according to me, treating a patient with PCOD only with homeopathic medicine or only with any medicinal therapy, not addressing the lifestyle part of it, is going to be something that we are half-heartedly looking at treating the patient. So, making the patient aware of what are the other, the other aspects of life that they need to change in order to get better with respect to their hormonal imbalance is very important, and it's very and it has to be much more consistent than even being on any therapeutic agent. Like if a PCOD patient probably has been taking homeopathy or has been taking allopathic medicines, if they are not following the diet and regimen, or if they discontinue to follow or maintain a typical kind of lifestyle, probably over years they might even the PCOD might even resurface, or they might even get those symptoms back again if they've gained a lot of weight, or they are not eating well, they're not exercising. So it's important for us as doctors to educate our patients or counsel our patients about the role or the importance of the allied part in managing the hormonal diseases, rather than just being prescriptive, or rather than just describing what medicine they need. uh, so when I approach hormonal disorders, there are various aspects to hormonal disorders that we need to see or we need to look at. First is that the role of relevant investigation. Now, I have put this point is, as I said, in my journey when I was seeing a lot of infertility cases, it was very it was very interesting to know their investigations, to know their reports, to know the state of their the sonography or HCG, or the various investigations that they would come to. And what was the role of those investigations for me in both prescribing the patient as well as understanding or judging my follow-up. So as a practicing homeopath, I need to understand that if I am seeing a patient of infertility, what are the various investigations that I am going to advise this patient? When I'm talking about various hormones, the hormone secretion keeps on changing as per the day of the menstrual cycle, or if it is depending on the age of the patient. So what is my interpretation of these reports that I'm seeing, and how am I going to change this, or how is it going to help me judge my follow up on the basis of the investigations I've done? Like, for example, a patient comes to me with anovulatory cycles, the cause of infertility being anovulation. And if I am to treat this patient, I need to understand the role of ovulation study in a female. I need to understand from which day do I start, where do I end, for how frequently do I send her. I also need to understand when will the rupture happen, what are the symptoms associated with the rupture of the ovum. I also need to understand that if I'm seeing an anovulatory cycle, in how many months do I see a change in that ovulation, or a change in the pattern of ovulation, and I will judge my follow up, or the efficacy of my medicine according to that. So it's very important or relevant for us to be very updated with the recent investigative techniques that are present, especially in cases of infertility, which are very multifaceted, being there can be male factor, there can be female factor. Even in females, we can have at various levels there could be problems. So if we are thorough with our a pro forma of investigation, that we are how we are going to approach an infertility case, it's easy for us to diagnose, and it's also easy for us to judge the follow-up for the same patient, that how the patient has responded to our medicines. uh, uh, Having said this, we've also seen, like when we used to see patient, there was a patient who was suffering from an ovulation, and we had, she was under a treatment, and I think in the second or third month we were seeing her ovulation study, and the follicle size wasn't growing till about the ninth or the 10th day of her of her cycle. And then we introduced doses of pulsatilla, and after pulsatilla we actually saw rapid growth in the follicle, and eventually the follicle ruptured. So So even if she was on a different constitutional medicine at that time, introducing pulsatilla helped her for that follicle growth and for the rupture of the follicle. So it's important to be in tandem with the investigation, and when to use and how to use those investigative approaches to see how your medicine is helping, whether it is helping or not, whether we need to change the medicine, the potency, the repetition, any of it, depending on what cases you're seeing, what medicine you've prescribed. So it plays a very vital role in managing the patient. You may treat, you may prescribe, but an overall management to assess the follow-up is the role of investigation, or the relevant investigation for the case play a very important part in the whole journey of the patient. Then the constitutional approach. So generally, if I am to treat a hormonal imbalanced patient, my first opinion or my first understanding is, if I can find out a constitutional medicine that acts right from the from the psychological aspect of the patient up till the pathology, then that is something I will look for. Because your hormonal diseases essentially being much more deep seated, they are not very acute changes in the body that we need to prescribe something relatively superficial. So an approach towards hormonal imbalance will at some point in their journey will include finding out that constitutional medicine, or that medicine that actually helps them through in a very in much broader spectrum than a specific would, or an acute medicine would. So the approach definitely lies, or the treatment will lie in understanding both the pathogenesis of the patient as well as the mental aspect of the patient. And when we correlate both of them, that is when we can come up to a remedy, leaving out either of it. Like if I am just ignoring the pathology, if there is a block, if there is an overgrowth, there is a cyst, or if there is infection, if I'm not looking at the pathology, I'm just looking at the mental state of the patient, I may still not be able to give the desired result. And if I'm only looking at the pathology and I'm not taking into consideration the mental aspect, the physical journals, which may be prominent, since it's a dynamic case, it's going to be a problem. So a balance between both the pathology and the presenting symptoms at general level, whether mental, general, or physical level, is something that we need to look at when we are treating hormonal cases. Uh, and that, in my experience so far, has given much better results than just use of specifics, or just use of a very mental or a Kenshin approach of treating the patient. Then is the role of intercurrent or anti-miasmatics. Now, this is something that I personally vouch for in general, but specifically in hormonal cases where we see a very prominent miasmatic expression, where largely they fall under psychosis, but they can go from psychosis towards tubercular, also some cases being syphilitic. But nevertheless, whichever miasm they may be depicting, but it's very important to take a note of what is the prominent miasm and what could be a probable intercurrent or an anti-miasmatic, if you are feeling that your indicated remedy is not working at the best. So if you've prescribed the constitutional, or if you've prescribed the indicated medicine, and yet there is a block, or there is that that dissatisfaction in the action of the medicine, even though the patient feels better, but you feel that you could have been a little better than this, or the reports could have been a little better than this, then I feel that in such instances, using anti-miasmatic or intercurrent really helps in cases, especially for infertility, wherein means if I have to give you an example, in our cases or in our experience, we saw a lot of cases with recurrent UTI in females in the past. They would have come to us currently probably with PCOD or with ovarian cyst, but in their past history, they had a history of a lot of UTI. Now, in current scenario, we don't really see a lot of STDs, but a recurrent UTI is also an expression of psychosis or psychotic miasm, and therefore a dynamic or an infective state in the pelvic cavity, a constant infective state in the pelvic cavity. We saw a lot of females responding nicely to a drug like medorinum or staphysagria. So it's very important for us to also see the case from a little from a little broader angle, where we take into consideration a lot of other things apart from the presenting complaint and the diagnosis. And if we get stuck, we use such techniques to increase the efficacy of our indicated medicine. uh, then use of specifics, as I said, in my practice I'm not somebody who will go first and use specifics, but yes, I will definitely vouch for specifics like polycolinum and uforinum, who have been useful in cases where constitutional case taking or getting of symptoms was difficult, or we could not get any characteristic symptoms, or we could not uh, we could not have the setting to understand the mental state of the patient. We have definitely used specifics. Even in thyroid cases, thyroidinum has helped a lot of patients. But eventually, I think in hormonal cases, even if you use specifics as your approach, but at some point you will have to think of a little more deeper remedy, so that the hormonal imbalance is corrected. Specifics generally will act as how artificial hormones are acting. So till you are giving thyroidinum 3x, the thyroid might be normal. The moment you withdraw thyroidinum 3x, you may see the patient return to the similar TSH levels, which generally will happen if they are taking Thyronorm. So a lot of times specifics may act in a very similar way of what artificial hormones would act. So I would suggest that if we are seeing a hormonal case, we along with specifics, we should figure out what is the constitutional, or what is that medicine which will act little more deeper than a specific and act, and which will act for a little more longer time than what a specific would act in that case. Another interesting aspect that I learned in my infertility, the experience that I got was the synergistic approach of treatment. So what we had done was, in few cases, we know of artificial reproductive therapies like IUI and IVF. So in our patients, what we've done is that we would take them for homeopathic treatment. We would ask them to go through the follicle studies, and we would study their follicle, and we would study when it has ruptured. And instead of them being under allopathic medicines or under hormonal treatments for this entire process of ovulation, they were on homeopathic treatment. And just for the procedure's sake, or just for the help of procedure, we had collaborated with a gynecologist, and they would do IUI on the patient at the time where it had ruptured. But the whole rupture or the whole ovulation was under the guidance, or under the whole management with homeopathic medicine. So what happens is, when we do this, or if we can do this more frequently, if we get a chance to do such procedures, a lot of patients who have a physical block of performing the sexual act, and the infertility is at that level, we can still get their hormones to be normal, and then we can use such assisted reproductive therapies for just using that mechanical support that few patients will need. So a synergistic approach is something that I would want to work in my future, if I can collaborate with some gynecologist, and we can understand that if we can remove the whole HRTs, if we can remove the whole hormonal treatment part of it, and we can just utilize their skill of the insemination. And if we can do that, I think we will have much better, we can help larger population, and we can use both the medicines or both the approaches synergistically. So this is something that I would want to also work for in my future, for for more time, that we can take the help of homeopathic medicines, get them better at their hormonal level, get their functions better, and then we can just use the procedures for removing the mechanical block if we have in some cases of infertility. And lastly, as I think I had discussed, the role of diet and regimen in management of hormonal imbalances. So it really plays an imperative role, where we cannot think of treating, especially female hormonal disorders, without changing their life, without changing their approach towards life, without making them realize what is the importance of all the three aspects: the diet, the regimen, the exercise, and the mental health. So all the three aspects of a female's life they have to be addressed when we are talking to them while treating. And we need to make sure that they are eating right, eating correct type of things and correct timings, and they are working out, they are following some or the other pattern of exercises, whichever that they like. And they are also being at a mental health, mental well-being, or they are consciously uh, making themselves aware of the need to be mentally healthy. Because when I talk about infertility, it comes with a lot of trauma, it comes with a lot of with a lot of mental aspect, mental pressure from the society, and a lot of things that go on, in a couple that goes through the whole infertility treatment, the whole disappointments of every month. It's very tough mentally to be there. So it's as a homeopath, we understand it better, because we are dealing with the case in much more depth than anybody else. And therefore the role of counseling, or the role of talking to them and making them realize how important it is for you to remain positive, remain healthy, or remain mentally at peace, is really important in managing the entire. Even if I'm giving a correct medicine, but if every time there is a lot of sadness, there is a lot of fear, there's a lot of anxiety, it may not act, or it may not give you the best of results as it would have if she would have been mentally much more fitter. So our role doesn't end in finding out the totality and just prescribing, especially in hormonal cases. It goes much more beyond in advising all the other changes that we see in that patient. And that will keep the patient with you, and that will also make have that belief in you that you are going to change their life, you're going to do something better with them. And they have that trust in you, and then you can even get the case better. So it works for both the doctor and the patient. And it is something that we cannot ignore, especially in hormonal cases, which are deeper. So this is in general what approach I use for a hormonal case. I'll just share a few cases that I have treated. So this is a case of hypothyroidism. A 30-year-old male. He was when I talk about hypothyroidism, it's very interesting that um, as homeopaths, we very rarely get a fresh case of hypothyroidism. Very rarely people with hypothyroidism will first come to you, and they'll ask to start homeopathic treatment. They would always be under some medicinal treatment, and they would come to you after a long time. So I have seen both the type of patients, and in my experience, if somebody who's not taken thyroid is like a blessing to us, we can treat them and we can get them to a level where they do not require homeopathy at all, and they are still maintaining their thyroid levels all by themselves. So my first case during my internship was of my friend, she was recent, she was detected hypothyroid at that time. Her TSH was about 8 or 9, and I treated her with homeopathy, and today, after probably 11 years, she's still normal. She's not got her thyroid back, and she's also not on my treatment for a very long time. So it's not difficult for us to treat a case of hypothyroidism if they come to you in the first way. But if you are seeing a patient, or you're seeing a case who's been taking thyroid for a long period of time, then our approach changes. So what we aim at when we are seeing a patient who's taking thyroid for a long period of time is that if the thyroid is not being managed, or it's being fluctuating, then we will aim at making it consistent, or making it much more steady. And gradually the patient's thyroid doses will definitely wean off if you're on the correct constitutional medicine. So one of my patients, she was taking thyroid medicine since probably 25 years, and in last few months she was off the medicines completely, and now she's taking a bare minimal dose of 12.5, which also will gradually be tapered off. So it we can also achieve that thing with homeopathy, where a chronic patient who's been taking allopathic for thyroid, we can stop their medicine eventually, but that might take a lot of time, as compared to what treatment we can give for somebody who's freshly diagnosed thyroid and is first coming to you for its treatment. So this was such a case where he directly come to homeopathy, and he was treated with constitutional medicines, and after probably few months of treatment, his thyroid was completely normal. And also this was to 2019. His last report of 2020 was also normal. So he is so far not on homeopathic treatment. He's not on thyroid medicines as well. So it's very easy for us to deal with cases which are fresh, which have not been changed with taking allopathy. This was another case of thyroid. Again, she had come with other complaints. She had primarily actually come with piles. She had a very typical complaint of hemorrhoids, which are aggravated before menses. And she also had a hypothyroid problem, which she was not taking a medicine for. And because she was not taking any medicine, and she just recently got diagnosed, this is a very recent case. I told her not to start with the medicine, and I told her we'll manage it with homeopathy. And I clearly remember that because she'd come with piles, and it was very painful, and it was very, very difficult for her to go through that agony. And after the first week of follow-up, she was absolutely normal with her piles, and she was extremely elated. And a lot of times patients who start feeling normal, they'll start not coming, or they'll start skipping medicines. But I had to counsel her that we are treating you for thyroid also, for which you will have to take medicine. You can't just rejoice the pain decrease of piles. You need to be consistent with respect to thyroid medicine also. So she was on the same constitutional medicine for both. And I think in June we did her thyroid, which came absolutely normal. And she's currently also on treatment, and my approach has still been constitutional. She's on her constitutional medicine, and she's better with respect to her piles. She's also better with respect to her thyroid. So it can be achieved. It's not something which is difficult, but yes, we have to be confident about it, and we have to be open about the fact that if we need to know that how much time a disease will take to get better, if and which what stage are we coming, because patient will always ask you kitna time, how much time will it take. This is the first question that any patient, or any as a patient, anybody will have that doubt. So judging that prognosis is very important for us to in our practice, and that kind of builds that trust between you and your patient. And this was an interesting case of cyst, which I had treated it. It was in my OPD of the college that I go to. So this female had come with an acute complaint, acute abdominal pain, and profuse menses and spotting intermittently. And she had done her sonography already, and she'd come to us, and she had a cyst of about 3.8 centimeters in her right ovary. And So we started treating her because she'd come too much with acute pain. She was prescribed an acute medicine for her pain, and then she was called again after a week, and she was reassessed for her constitutional picture, and then she was given constitutional. And after 2 months, we again, so after that, she never got the pain, she never got spotting, even her menses, the dysmenorrhea had settled. So 2 cycles I waited. So because 2 cycles were absolutely asymptomatic, and in between there was no spotting, there was no pain, I advised her to go through the sonography again. And the repeat sonography absolutely showed resolution of cyst. So she was actually scared because she was advised surgery by her doctor after seeing the sonography. That's when she came to homeopathic OPD, and she was absolutely happy. And then she never had any symptoms pertaining to menses whatsoever. She was on. She also had certain associated complaints, which also gradually came down with constitution. I think with 6 months she was there with us, and she was far better, and there was no relapse of any menstrual complaint. So I think we have a very good scope in hormonal cases, and if we pick up those hormonal cases and if we treat them, we are really helping them avoid a lot of painful medicines, the lot of side effects with hormonal medicines. The procedures are expensive, the procedures are tough mentally. So if we can give an answer to those type of diseases which are so much prevalent in the current scenario, the kind of food that we are eating, the kind of environment that we are living in, this is only going to grow, it's not going to get better. So as homeopaths, if we understand our role in hormonal, if we identify such hormonal disorders, and if we give confidence to our patients, I'm sure we'll really have a good scope in that, and we can help a lot of people with our therapies. So yeah, so that is it from my side. I really thank you all for being patient with me, and I hope the session was good enough. I think I got it at a very short notice, so I couldn't really collect a lot of cases, but I hope it helped and it was relevant. Thank you.
Thank you, doctor. Thank you so much. If anyone have questions, please raise your hands. Okay, Dr. T.N. Sridharakurup. Okay. Sir, you can talk now.
Yes. Dr. Shyama, thank you very much. It was excellent that your session was excellent, class was excellent. So I was remembering, I was teaching anatomy and pathology in 41 years back. So I was remembering, sometimes we may require the knowledge of anatomy, physiology and pathology, etc. are essential to sometimes to treat the diseases. So very good, excellent. Thank you very much.
Thank you so much, sir. Thank you so much. I'm
so
really happy it's coming from a teacher. It's really encouraging, sir. Thank you.
Yes, I was teaching the profession first. Then I came to research. Then I realized the primary knowledge of anatomy, physiology, and pathology. Definitely, it will improve our knowledge.
Yeah, especially in hormones, because they are secreted in a very typical pattern, and they have their typical peaks and lows. So we need to understand that and then interpret the reports. Somebody gets us FSH report, if we don't know when they have done which day of menstrual cycle, it's very tough for us to just diagnose on the FSH. So the correlation of normal levels of hormones, when do they peak, when they are lesser, it's very important when we are dealing with especially infertility, I feel.
Thank you.
Yeah, thank you, sir. Thank you, sir.
Okay, please.
Dr. Sridharakurup. Next, Dr. Logamani Gupta. Dr. Logamani Gupta. Okay. You can
Hello.
talk.
Hello. Am I audible to all?
Yes.
Yes, sir.
Thank you. With all the good wishes to every participant, a very good scientific presentation by Dr. Shyama Bora ji from Mumbai, India. I congratulate herself for the good work done by them. Ma'am, now few questions. If thyroid hormone of a lady is okay, what other tests you recommend to them in case of
I
infertility?
can't hear you, sir. Sorry.
If
Can you
a very good presentation done by you, scientific presentation, I congratulate you for the time needed presentation. This is the only way we can bring our homeopathy number one in the world. So my question is, if the thyroid hormone, this TSH is okay in an infertile lady, what other tests you recommend to them or we should conduct on that patient?
if the thyroid hormone is normal, you're saying?
Because the hormones are synchronized process. So where we should hit the target to get the hormonal imbalances.
So if the thyroid hormonal assay is normal and if we're still suspecting a thyroid disorder or the symptoms are pertaining to it, we can get us USG or the uptake, the iodine uptake test done for the thyroid, which will tell us more about the functionality of the thyroid hormone. Also, thyroid is very much associated, or it very frequently comes along with other, if it is an autoimmune type of thyroid, it again it's very closely related to other autoimmune diseases. So if somebody is also giving you a very faint complaint of joint pains, then you will look at it as an autoimmune process also, and you would want to rule out RA or any other autoimmune diseases that is pertaining. And if that autoimmunity comes positive but your thyroid is still maybe on a normal level, you would get an antibodies for thyroid specifically done to understand whether it's an autoimmune type of thyroid. So in just with FT3, FT4, TSH, a very primary type of hypothyroidism can be still diagnosed. But if it is an autoimmune type, or if it is correlated with some other diseases that are related to thyroid disorders, we can accordingly change our line of investigation and then understand the final diagnosis.
Any role of luteinizing hormone?
Any role of utilizing hormone in thyroid?
In infertility?
Infertility, actually the understanding of utilizing hormone only before ovulation is what we clinically would want to know. So there are tests, if we don't want to go invasive, there are kits for ovulation that will detect the LS surge that happens before ovulation. So we can ask the patient, if not they want to go for the blood test, they can get the kit, they can get the ovulation kit, and they themselves can, it's very similar to urine pregnancy test. So they can use that kit and they can understand when the LH surge happens, and then we can confirm whether the ovulation will happen or no. But otherwise, in infertility cases, we've seen the LH the LH will go high because the ovarian response is poor. So if there is an ovarian failure, a case where the ovary is not responding, then the corresponding hypothalamic hormones, the FSH and LH, they generally rise. So an LH which is higher than normal, done in the during menses, during the menstrual phase, and the patient not conceiving, probably indicates us ovarian failure in that scenario.
Thank you. Thank
you, sir.
Thank you, Dr. Logamani Gupta. Next is Dr. Hubert.
Thank you very much. Can you hear me?
Yes, yes.
Can you hear? Yeah, thank
Yes,
you
sir.
very much, madam. I want to ask why you said that PCOD is a lifestyle disease.
So PCOD is seen as a lifestyle disorder because PCOD also, or now even PCOS, comes with a very increased probability towards insulin resistance in the future. So people who are females who are PCOD or PCOS patients, in future they are likely going towards developing diabetes, and it's called as a metabolic syndrome, where there is obesity, there is diabetes, and there is PCOD. So therefore, in patients of PCOD, we emphasize the role of exercise and correct diet, because it helps in keeping the insulin response normal in the patient. So that's why it's seen as a lifestyle disorder, where we ought to change their lifestyle. We ought to inculcate the fact that they can in future progress towards diabetes or other metabolic, like obesity, and therefore that's how it is seen, and that's how lifestyle changes are also advised in PCOD.
I have seen most of the patients are in teenagers, we can see. Isn't
Yes,
it?
yes,
Teenagers.
yes.
That time we can see that these complaints are more original. The next question I want to, there are three more questions, two more questions. You did not said anything about the treatment pattern you have done.
Treatment pattern?
The two cases, the last case,
the ovarian cyst case?
That's third case. That is ovarian cyst.
So the third case had come to the OPD with acute abdominal pain. So at that time we gave them acute medicine. I think, if I'm not mistaken, the medicine was belladonna. And after that we called her again, because in her acute pain she could not give us any symptoms for her chronic totality or for her constitutional. So we gave her the acute medicine, we sent her home, and she was better. She came back after a week, and that is when we actually took the whole case details, and after which we came up with the constitutional medicine, and we prescribed her the constitutional medicine. I think the constitutional, if I'm not mistaken, it was sulfa at that time.
I had seen a case of TSH 106. 106, a lady of 32 or 33 years. What may be the possibility of that condition?
So if it is beyond, if it is that high, as I said, it comes along with a lot of autoimmunity. So if it is going beyond that range, we need to look at the autoimmune aspect, or the presence of autoimmune antibodies in the patient. And also, if she is having any other autoimmune condition along with it, then it still increases the possibility of her being having an autoimmune thyroiditis.
Thank you very much. Thank you very much.
Thank you.
Next is Dr. Beatrix. You can ask question now, madam.
Thank you. Thank you very much for the very, very interesting presentation. I was a bit late, but at the end also your cases. I would very much be interested to understand if you're like in the case with that lady with a cyst. You're talking about acute and constitutional therapy, that's clear. Could you talk a bit about the potencies? If you are treating a case of hyperthyroidism, are you giving potencies every day like LM, or you're giving higher potency in a certain level?
So generally, if I'm beginning a case and if I'm seeing the similarity is good, then I will definitely begin it with at least 200 to 1M if I'm confident. If I'm seeing a case which is poor in its similarity, or if I'm seeing more pathological, I'm not seeing more symptoms, characteristic symptoms, then I may use 30. But generally, I use 200 and more than that. LM is something that I have got into very recently, and I'm loving it. So I would always want to explore that aspect myself also. I have been recently giving LM scale to 3-4 patients of mine who are doing fantastic with LM scale. And if we are, if with 200 the patient you feel is getting better, but the pace of recovery is relatively slower, then I would want to switch on to the LM scale directly. But even if when I'm giving 200, I always give in water medicine in water potency so that I can repeat it on a daily basis. I don't give a single dose, because I believe that currently we are living in an environment which is full of a lot of maintaining factors. If I have to treat somebody and I have to tell them that refrain from stress, refrain from worries, or refrain from eating something outside, it's very tough for people to do that. So according to my understanding, if a maintaining cause is persisting, then my medicine also has to persist for its action. So because the whole scenario is such where I am seeing patients surrounded with all the negativities and I can't remove all of them, I would give a positive force every day. So I generally repeat it, but I repeat it in water. I don't repeat directly the dose. I dilute it and I repeat it frequently as it has been given in Organon.
Thank you very much.
Thank you.
Thank you, Dr. Beatrix. Next is Dr. Munawar.
Okay.
That was a nice presentation, Doctor. And I was just wanting to also add up, as per my experience also with the polycystic ovaries being a lifestyle disease. I think basically because women are, donning a lot of roles in today's modern life too, as we have seen in the last couple of years. And because of the venturing into a lot of whether it is software related job or not having sufficient exposure to vitamin D and the natural sunlight, plus not being able to take care of themselves, self-care, and also being stressed about providing for the family or being equal breadwinners of the family. I guess all putting together along with some vitamin D deficiency also, which we have seen, can lead to polycystic ovaries and can also be a lifestyle disease. Plus, now, of course, you have very well explained. There is a very nice correlation between polycystic ovaries and fatty liver, and polycystic ovaries and thyroid related disorders.
Correct.
So I've been also treating for the last 25 years, and I see a very, very strong correlation between all of these and serum insulin resistance as well.
Yes.
And hence, you have remedies which can work for constitution wise, miasmatic wise, as well as helping them overcome the cyst on the physiological or pathological aspect as well. So anyway, it was a nice presentation overall.
Thank
I just
you.
thought of adding my points, Doctor. Okay.
Yeah, I think I want to add one thing that you very correctly said, that the women are donning a lot of roles currently. I always correlate it to the fact that I'm sure females of our probably our grandmothers and their parents, that generation also would be having some of the other hormonal disorders, but because they were so physically active but mentally stress free, their manifestation was not there. They would do all, at least in India, they would do all the work themselves. They were physically overactive but mentally very peaceful. They never had any stress of proving themselves or anything like that. And therefore their conception, their fertility rates, their hormonal health was far more better than what we are seeing
better than what it is today.
In spite of the fact that today's girls are more educated and they are more understanding of their mental state, yet they are not healthy.
Correct. Very true. Very true. And we see that very common these days. So it's anywhere between 14 years to about 40-45 years also polycystic ovaries can exist. So I think we need to give women the benefit of doubt, and people need to be having a more understanding approach towards them as well.
Correct,
so thank you so much, Doctor, once again, and it was
Thank
a nice
you, Dr.
presentation.
Munawar.
Thank you. Bye-bye.
Thank you.
Yeah.
Next is Dr. Harinarayana Prasad.
Yes.
Dr.
Please unmute Dr. Harinarayana Prasad.
Yes.
Hello. Hello.
Yes.
I found that infertility anti-insulin very is high, and if anti-insulin is low and FS is high, what is the treatment in homeopathy?
Sorry, I couldn't
anti-insulin hormone is low.
AMH. Oh,
AMH in the found in the northeast India, AMH is very low. I practice in the northeast 20 years, and I found out AMH anti-insulin hormone is very low, FS is high.
Yes.
testosterone is very high, but
Yes.
prolactin is high. What is the treatments?
So I would really want to take this question and share my experience. So AMH is an hormone that generally falls down with the fertility. So more the fertility, better is the range of AMH. It becomes high in PCOD and it becomes low with lesser fertility or lesser follicles. So it's basically a correlation between what number of follicles the female has in her ovary and that corresponding hormone is being secreted. So that is one hormone that is technically used by doctors who do IVF. So they study the AMH and then they will stimulate the ovary accordingly and they will pick up the eggs, because that tells them about the reserve of the eggs of the ovary. So technically the number of or the reading is much more important for people who are doing IVF. When we had patients of infertility, there was a patient, she was 37 years old and she conceived with AMH as low as 0.014. So, which is a very low level for AMH. Even IVF people might agree with that. So, we have patients who have conceived with very low levels of AMH. So, AMH technically does not really matter as much for us as much the normalcy of other hormones. AMH is just an understanding of ovarian reserve, but we just need one good egg for conception, and if we can healthify whatever reserve the female has with whatever constitution or whichever medicine that we are giving, I'm sure we can give results even with lower AMH.
Okay.
FS is high.
Okay.
Sorry?
FS is high.
FSH, as I said, FSH and LHI will depict two things. Either the so in physiology it depicts menopause, and in pathology it depicts ovarian failure, which is also another. Which is a premature menopause, as we say it. So if FSH and LH are high, we are dealing with a patient whose ovary is not responding to the hypothalamus or the hormones of the hypothalamus, and therefore accordingly we need to give medicine, or we need to give a treatment or an indicated medicine which will cover either if your approach can be specific, you can use something like folliculinum or euphorhinum, or if you want to use a constitutional approach, you can take the entire case and understand the constitution and prescribe.
Okay.
Prolactin high
Generally it also causes infertility, but not as much responsible, but it's more seen in problems or in cases with some adenoma or pituitary adenoma or any pituitary lesion. So raised prolactin, most common diagnosis is a pituitary adenoma rather than any reproductive organ failure. So it not very frequently it will interfere. If your FSH LH is normal, then prolactin can be, it will reverse or it will be negatively inhibited. So
Yes.
that's not a problem that we have seen at least in infertility.
Next one.
Asta Jain, Dr. Asta Jain.
Yes, ma'am.
Question, and we have 2 minutes. Make your question short.
Sure, ma'am.
Okay, thank you.
Good evening, ma'am.
Good evening.
I have heard somewhere that CPR1M is best in infertility cases. Is
Correct.
it true?
I think CPR1M
is given to females who doesn't conceive easily. CPR1M
I feel one first answer that I want to give you is CPR is a wonderful female remedy any which ways. So
Yes,
you can prescribe CPR in a lot of female complaints.
Yes.
Second, personally, very recently I treated a case of actually recurrent abortions in CPR where the conception is very easy. So in my experience, if you ask me, I've given CPR, I've seen CPR being prescribed to females who have a rather easier conception, but maintaining the conception is the problem, means there is recurrent abortion. So conception mein problem nahi hai, to maintain that conception, to maintain that pregnancy, that is the problem. That's where I feel CPR will act better than in the pre-concept, in that case.
You have used it? In which
Sorry?
potency?
I had used it. I started from 200 and I went to 1 M.
Okay. Thanks, ma'am. Can you share your contact?
Sorry, I couldn't hear you.
I think there is some network problem. Dr. Badran also raised his hand. Dr. Badran, you have 1 minute for asking question. Dr. Badran, please.
Thank you. Thank you, madam. Your presentation was very nice and inspiring, and the physiological and pathological correlation was very fine. But one point I can't agree that homeo medicines should be taken as maintenance dose, like allopathy medicines. It can't be agreed. Why? Because in thyroid case or PCOD or menstrual disorders, we require a maintenance dose. Some 3 to 6 months treatment or 1 year treatment may be needed, but can correct spontaneously. And no need to maintain. What I mean is a maintenance dose is not needed as per my experience is concerned.
I couldn't understand. What is not needed, sir?
Maintenance dose.
Maintenance dose. No. So that's what I said. I don't repeat that dose. I divide that one dose and I'm giving it frequently. So we can, you can give that single dose at a time and then wait for 2 weeks, 1 month also. But because I think in Organon that we read, eventually even Dr. Hahnemann also suggested water-based medicine or water doses which can be given frequently to passive, to increase the pace of your cure. So at least in my practice over the years, I have seen that water-based medicines are helping in increasing the pace of your cure. So what you could do in for probably 5 months, if you are repeating frequently, but in water, you can achieve the same result in say 3 months. So yeah, that is what I have seen. But yeah, it can be a very individual understanding.
Okay, thank you, Dr.
That's right, and agree.
Actually, our Malayalam other session is from 9:30 to 10:30.
Okay,
so,
okay.
Dr. Manoj, please give vote of thanks to.
Thank you, Dr. Rajini. Nice presentation. You had almost collect all the things, very much important over the practice. So, congratulations. And on behalf of IFPS, I am expressing my sincere thanks to Dr. Shyama Bora and those who are all participating in the program and discussion. Thank you.
Thank you so much. Thank you, everybody, and it was a nice session, nice experience, and thank you for all the doubts. I hope I have.
Thank you for being available with a very short notice.
Thank you, Dr. Sajid. Thank you. Thank you.
Over to the next session for the Malayalam. Thank you.
Bye.
Thank you, Dr. Sajikudir. Am I audible? Hello, am I audible?
Yes, you are audible, Doctor.